It's going to be trauma. We're going to focus on the infectious side of it. And we are not even going to really scratch the surface of all the things that can, infectious-wise, cause an encephalitis, which we're going to handle a few of them. But let's just think about this. If an infection gets into the actual brain tissue, the actual brain, causes a bunch of inflammation to the brain, the diffuse gray matter, the capillaries that are carrying all the blood to all the spots in the brain now become permeable because they're inflamed, they're leaking blood all over the place. What are some of the symptoms that we might see, signs and symptoms that we might see? What's that? So nuchal rigidity is likely, much more likely in meningitis than encephalitis, but not off the table. Headache, huge headache, fevers. You guys familiar with the phrase focal neurologic defects? Right? If there is a brain spot, central nervous spot, or nerve spot that's being occluded, infected, or something complicated, where that nerve goes in the body, you can have problems as well. But this is just like global global neurologic defects. What about their personality? Would that change potentially? Sure could. You guys ever heard of the word delirium or delirious? It's like acute, sudden change of mental status, personality, etc. That can be possible. Seizures, 100% possible. Paralysis is possible. It's just kind of like all over the place because the entire brain is being impacted. So it's quite problematic. Incredibly painful. Incredibly painful. Meningitis is different in that it's not the actual brain tissue. That meningeal layer that serves as a protection around the central nervous system that has all those tiny little nerve fibers and fingers, and this little tiny little bit of fluid that creates a buffer zone. If that gets inflamed, still incredibly painful, still has a lot of the same symptoms. But one of the bigger delineating factors there is, a gentleman said, nuchal rigidity. That neck stiffness and pain tends to be a lot more problematic because anytime you start to move those muscles of the spinal cord, around the spinal cord, it starts to stretch those meninges and it's incredibly painful. It's a little bit of difference there. But either way, viruses can cause them, bacteria can cause them, amoebas can cause them, protozoa can cause it, all that stuff. All right, so just generally speaking, encephalitis, inflammation of the brain, very commonly viral, could be bacterial. The virus, we just described, invades the brain and the spinal cord, the central nervous system. That could be, it could be primary, just meaning the virus straight goes to the central nervous system. It could be secondary, meaning there was an infection somewhere else, that infection then spread to the central nervous system. Really kind of impossible to always know or predict what's going to happen, but those are just a couple of ways that infection can get into the central nervous system. All right, a short list of many, lots of potential causes here. Herpes, varicella, MMR, measles, mumps, rubella can cause it. Arboviruses, do you guys remember what arboviruses means and or stands for? What's that?
Tree viruses.
So actually, I love it because you're actually trying to break down the word Latin-wise, which is, you guys realize most medical terminology is Latin, right? It's not a spoken language anymore, it's just a written language. So, but this one is actually a series of kind of abbreviations. R is short for arthropod, bor is born. So arthropod-borne viruses. So things, fleas, ticks, mosquitoes that carry viruses, that's what that's talking about. Rabies, oh look, Naegleria fowleri, and toxoplasmosis. All of those are possible causes of encephalitis. All right, the portals of entry to this central nervous system, it's kind of variable based on what the virus is. We're talking about viruses primarily right now. Virus is that's getting into the central nervous system. You can read through that, but that kind of makes sense, right? Not everything's going to get into the central nervous system the exact same route. Once that virus passes the blood-brain barrier, you guys heard that phrase before? The blood-brain barrier, that kind of thin layer of blood that insulates the brain. The virus enters the neural cells themselves, disrupts the functioning, and then that word perivascular congestion and hemorrhage means that as that virus gets in there, starts to replicate, creates its congestion, much like we talked about with malaria, that kind of decreases the ability of that vasculature to keep the blood inside, and it starts to leak blood, toxins, etc., onto the actual neural tissue as well. At the very bottom, he says that the symptoms can be focal or diffuse. It's kind of just all over. Now, if you've ever had a headache, you can appreciate it can be pretty painful, right? A lot of these, especially viral encephalitis, are symptomatic or supportive therapy. I think sometimes when I hear that phrase, I kind of imply, okay, so it's not really that bad. Encephalitis is terrible. Meningitis is horrible. Anybody ever been around somebody who's had encephalitis? No? I've had a couple of coworkers that have had a viral encephalitis before when I worked in the fire department, and they were gone for weeks. When they came back, I'm like, man, are you okay? He was like, I was in bed for days. Like sound had flavor and light had music, and it's just everything hurt. Couldn't do anything. So it's actually can be very, very painful, and it's just a matter of time for the body to recover from it if it's going to recover from it. All right, you kind of started to scratch the surface on these, and if you were to read through these, it makes a lot of sense. But if there's an infection of the actual brain, the brain is in charge of all the neural stimuli as well as the reception and interpretation of it. It's going to have a lot of symptoms that are secondary to that. So fever, headache, nausea, behavioral and personality changes, level of consciousness. You've got the stiff neck in there, absolutely. Photophobia, lethargy, seizures could be generalized or local. A lot of confusion, and it can even be some flaccid paralysis in there. It's kind of almost whatever the brain chooses to do in response to the infection, or the inflammation, I should say, not the infection. The inflammation, the body will react secondarily to that. All right, when it comes to the physical exam, lots that we can tease out here. Altered mental status tends to be one of the most common that we will see. These individuals are not feeling well. Their brain is what's being impacted, so they're just not going to be their normal self. Anybody ever deal with a sick kiddo? Maybe you had a sick kiddo, and they're just kind of like not themselves, a little more angry, a little bit more punchy, or something like that. Their mental status changes a little bit. Similar scenario here. Hemiparesis, focal seizures, autonomic dysfunction, all of that makes sense. Movement disorders, ataxia, cranial nerve defects, dysphagia, meningismus, all of that makes sense. All because of this kind of like broad spread inflammation and permeability of the vasculature and the neural cells themselves within the central nervous system. All right, some labs and diagnostic procedures that will help us. The talks about performing a head CT early. A head CT does not necessarily mean it's going to be diagnostic to us. A lot of times we need to get cerebrospinal fluid. We always do a head CT before we do a CSF or a lumbar puncture. Anybody remember why?
Sick right now.
So we don't want the herniation, absolutely. So we are doing the head CT for signs of intracranial pressure. If we can see something that might create pressure inside the cranium that is abnormal, maybe signs of pressure inside or a space-occupying lesion, that once we open up that intrathecal cavity down there in the lumbar spine, all that pressure then herniates down through the brain. That'd be terrible. So we always do a CT first. The CT, we are not overtly looking for the diagnosis. Sometimes we might get some help in it, but we're really looking for, is it safe to do lumbar puncture? All right, general treatment. We're just talking about general encephalitis. Mostly supportive. A couple of exceptions. There are some viruses out there and bacteria out there that we can throw some antivirals at and antibiotics at. But for the most part, we got to keep these people comfortable, got to keep their fever down, got to give their body the support it needs to recover on its own. So lots of fluid replacement, lots of nutrition, avoid secondary infections. Hyperpyrexia, if you guys haven't heard that phrase, it's just a really, really bad fever, like above 105, 106 level, really, really high fever. And then manage the intracranial pressure. Head elevation, diuresis. Mannitol is a very powerful diuretic. It can take a lot of the fluid off of the system and decrease the intracranial pressure. I don't know why the word seizures is underneath manage intracranial pressure, because I don't think we would induce seizures to manage an intracranial pressure. I think that accidentally, when this was created, got just tabbed over. We want to manage and monitor for seizures as well when encephalitis and meningitis are at play. All right, a couple of specific ones we will talk about. Herpes simplex encephalitis. That's what the E and HSE stands for. Pretty rare. This is a reactivation of the herpes simplex virus. So when we were talking about different ways that stuff can get into the central nervous system, this is one where that herpes simplex virus lays dormant in the trigeminal ganglia, which is a cranial nerve. You guys remember which one the trigeminal one is? Yep, exactly. So it's in the actual brain, the nerve roots and the actual brain, and then it activates itself and it can cause an encephalitis. And then this third sub-bullet down, it's not associated with active disease. So not typically is it related to, oh, someone's got a cold sore, so there is a herpes simplex virus at play, so now we got to do monitoring for encephalitis as well. Doesn't mean that it can't overlap, but usually this is the dorsal root ganglion flares up and it actually inflames the brain parenchyma itself. It is also possible that the central nervous system spread through the olfactory tracts, and that's kind of what we described a second ago when I was talking about Naegleria. That spread can actually get through the actual tract where the olfactory nerve is and go to the central nervous system that way. Look at that mortality rate, 50 to 75% mortality rate. That's a high number. And then almost a complete 100% long-term motor and mental disability. This is a big deal. All right, some signs and symptoms, HSV 1 and 2. They do have some subacute forms. A lot of psychiatric symptoms, and again, that altered mental status, personality changes, is kind of a big deal. Definitely needs acute evaluation. There is anterior opercular syndrome. Anybody heard of that one yet? So it has another name, Foy-Chauvenet-Marie syndrome. Have you guys heard me talk about how many dead doctors it takes to name something? Yeah. So 3 dead doctors. What does it tell you about the rarity of this disease? It's probably pretty rare, right? And so what this is when the encephalitis hits a very specific spot in the brain, you will get like global paralysis or paralysis of the muscles of the lower half of the face. So the tongue, the masseter, the lips, the facial muscles, they're just completely paralyzed. So that's what anterior opercular syndrome is. Could have brainstem encephalitis as well as myelitis, and then just global aphasia. All right, to diagnose it, PCR, CT can be helpful. You might see some lesions, etc. And then, of course, we'll talk about cerebrospinal fluid and what are some commonalities of different types of encephalitis and or meningitis pathogens, whether it's bacteria or virus, etc. Treatment for this one, we do have an antiviral, acyclovir, which can be quite helpful in herpes simplex encephalitis. And then once they started using this, once they recognized what it was, significant decrease in mortality rate, which is awesome. All right, arbor viruses or arthropod-borne viruses. This is viruses that are introduced to the system through some type of arthropod or a vector. These are some examples of them. West Nile virus. I don't know why, but when I was a kid, I thought that was going to be as problematic as quicksand. Anybody remember quicksand when you were growing up and you just realized, everybody like overtly afraid of quicksand? Like, I thought it was going to be a much bigger problem in my adult life than it ever really was. And thanks to the DARE program, I was equally scared of somebody randomly offering me drugs. I've also never had anybody randomly offer me free drugs. So, thank you, whoever built the programs in the 80s. But West Nile virus, I was equally scared. I was petrified watching the news at night, afraid that somebody was going to bring West Nile virus to America and we would all die. But here are some other examples of encephalitis that are secondary to arthropod-borne vectors. All right, arborvirus, it looks like a normal encephalitis. However, it can be accompanied by dysuria and pyuria. What symptom is that describing those right there? Urinating. So difficulty urinating or painful urinating. How would an encephalitis cause difficulty or painful urinating? Any idea? Sounds weird, right? Like, what is the connection there? You guys heard the phrase neurogenic bladder? It's an actual neurovascular, a neuronal cause of bladder dysfunction. It could be overactive bladder, underactive bladder, or the brain can interpret pain with urinating, but in reality, the issue is not in the actual bladder or urethra, it's in the actual nervous system. So this can inflame a part of the nervous system that can actually cause dysuria and pyuria, not because there's an infection in the GI tract, but it is touched into that neurogenic bladder situation. So St. Louis encephalitis, we're not going to go in depth about this. This is much more just a picture of brain tissue that was impacted by an encephalitis. Does that look like normal, healthy brain tissue to you? Like that is just grossly inflamed, bloody. Obviously, this picture was taken relatively soon after expiration of the patient. But that does not look like normal, healthy tissue that was not sleeping very inflamed. All right, some labs and diagnostic options, leukocytosis and EEG changes. Are those specific for what the pathogen is? Not really, but it can help us know that there's something going on that's probably infectious and probably in the central nervous system. Supportive treatment, like that's the treatment for this stuff. We got to just kind of give the body what it needs to survive and hope that it does its job and does its job well. Obviously, prevention is a phenomenal option. Once somebody has it, though, you can't really prevent it. But if you can prevent yourself from getting bitten by these vectors, it would be helpful. All right, a couple notes on the West Nile virus. It's a flavivirus. Typically in the summer, early fall, and can be year-round in southern climates. I'll let you read this. Again, this is why I think we were so scared of it back in when we were younger, and now it comes into everybody's purview now. All right, so signs and symptoms. Most people are relatively asymptomatic or only mildly ill. The symptoms look like a typical encephalitis. So you got your fevers, your headache, photophobia, neck pain, stiffness, could have some altered mental status, could have some paralysis and/or seizures. Typically a large extreme lethargy. Leukopenia and serologic testing is possible. And then again, just supportive therapy. Viruses, really, there's not a ton that we do for viruses when we have them unless they're a very specialized type of virus. A lot of supportive therapy for the viruses and etiology. All right, going to move over into meningitis. So encephalitis, we did not even go super in deep about all the things that can cause encephalitis, just touched on a handful of known pathogens for them, and some signs and symptoms of it, and some treatment options of it. So meningitis, seems like there's a bigger possibility of getting meningitis in one of your patients than encephalitis. I have seen meningitis in the outpatient clinic many times, in hospital state as well. Encephalitis, only a handful of times. And most of the time that I saw encephalitis, it was usually hepatic encephalopathy more than a true encephalitis. Right, so meningitis, you see that layer that forceps is pulling back, that meningeal layer, that's what's impacted. And then, of course, it sits right there on top of the central nervous system, protecting it. And so inflammation of the meninges is what's happening in our situation of meningitis. Several ways that it can get there: through the bloodstream, through a retrograde neuronal pathway, and so kind of similar to Naegleria again. That olfactory nerve, which is just kind of ending right in our nose, all those nerves right there absorbing the smell particles. Bacteria can get on those and find their way to the central nervous system. And then it could be either direct or secondary spread, like through a sinusitis or otitis media. All right, bacterial meningitis. Bacterial meningitis is a big deal. It's a bad day for people. A significant cause of morbidity and mortality. Before the HIV, the Haemophilus influenza B vaccine, most cases were Haemophilus, Neisseria, or Strep pneumo. Because the HIV vaccine is in play, bacterial meningitis has significantly decreased, and now a lot of it is Neisseria that is causing it. Anybody ever heard of somebody say that they got to get the meningococcal vaccine to go to college? That's what they're trying to help prevent here, is because meningitis often happens in close quarters, and so they're trying to help these individuals that are going to live in close quarters, like college dorms or something like that, and then increased ability to resist meningitis. All right, here are some classic symptoms of meningitis. And there on the bottom right, you see a triad: fever, mental status changes, and nuchal rigidity. Remember when we were talking about encephalitis, I had mentioned like nuchal rigidity, it can be there, but it's just not as prominent as meningitis. Anytime that you see a triad of anything in medical teaching, just circle it, highlight it, square it, asterisk, whatever. But this triad of fever, everybody has fever, mental status changes, well, that can be encephalitis or meningitis, plus nuchal rigidity, it can be a pretty good pre-predictor of meningitis instead of encephalitis. There are two wildly famous physical exam tests / signs that people use for meningitis and encephalitis. Have you guys heard of the Kernig's and Brodzinski's sign yet? You have? Perfect, so then it's just review. I don't think I have taken a medical test yet where this topic was potentially to be tested on, but they have not added Koenigs or Brzezinski's. So I just kind of memorized them early, and to me it was always a free, easy 2 points because once you learn them, they just repeated on so many different tests. But the Koenigs sign, I'm going to try to kind of like explain why this happens. Because it doesn't really make sense why raising a leg should cause nuchal rigidity. But you got your central nervous system that's going to be up here in the brain, right? Then the central nervous system extends down the spine, and right next to the spine, which is protected by the vertebrae, it is pulled and tugged on by huge muscular straps called those paraspinous muscles. Anybody do any hunting? You guys know what the backstrap is, or the beef tenderloin? That's the muscle that lives right there next to the spinal cord. So when somebody lifts up the legs straight while they're laying supine, it actually takes and it pulls that paraspinous muscle towards the pelvis. That then pulls the vertebrae, which then tugs on the meninges, which are inside the central nervous system, inside the spinal cord. So these individuals will start to feel that tug from those muscles, start to feel the pain, and immediately either have pain or just simply resist the motion itself because it's so painful. So with the Koenig sign, if you've got somebody laying on their back, you kind of flex their knee and their ankle to 90 degrees, right? So thighs straight up in the air, the leg is the knee and the foot is or the shin is perpendicular to the ground, and then you try to extend the knee, which would normally make that hamstring tighter. If they have significant pain in the hamstring and in their back, it's a positive Koenig sign. Or if they will just simply resist it, they won't even let you do it. That's a positive Koenig sign. The other one, which is very famous, is a positive Brzezinski sign. If you were to take that head and passively flex the neck, which again is going to pull on those muscles, which is then going to pull on the vertebrae, which is then going to pull on the meninges, it causes a lot of pain as well. And those individuals just simply won't let you do it once you start to pull on it. So nuchal rigidity is just simply stating that the nuchal muscles or the neck is rigid. And it's not rigid because they're having a seizure or they're spasming. It's rigid because the patient refuses to move them. Because as soon as they start to move them, it starts to pull on all of those meninges and it causes a lot of pain. So the Koenig sign and the Brzezinski sign are things that you could do to amplify your physical exam in evaluation of a possible meningitis. So any headache that I would have in clinic, I would tell myself, Kev, you've got to rule out the bad stuff, right? So you got to rule out thunderclap, subarachnoid hemorrhage, stroke, meningitis, something of that nature. And so I would evaluate for nuchal rigidity on everybody. If there was no nuchal rigidity, in other words, they were willing to move their head all the way up and down, just like that, the chances of a positive Brzezinski or Koenig sign is 0, right? And so I wouldn't even do past that. If it was kind of equivocal, I would do the Brzezinski and Koenig sign, and then of course documenting, whether it was positive or negative. I think I told you, and if I didn't, I'm sorry, I'm going to tell you again. I had a patient we diagnosed with aseptic meningitis, secondary to going on Bactrim or Trimsulfa for a cellulitis. And that's a medicine that's known for causing meningeal irritation or aseptic meningitis. So there was inflammation to her meninges, and she came in and she was like, yeah, I think my cellulitis is getting better. It's like 2-day follow-up. Like, but I don't know why I have such a bad headache. And I was like, and she kind of had like the bad headache vibe, right? People were like kind of like closing their eyes, being real still, didn't really like to talk, didn't like loud noises either. And I was like, do your eyeballs hurt you? She's like, oh, my eyeballs are killing me. I can't look at anything. I have to have the lights dimmed all the time. And I was like, okay, cool. You want me to talk softly? She's like, please, you're so loud. To be fair, I know I'm loud. Insert laughter here. So then I was like, okay, do this. Shake your head. Yes and no. She goes, oh. And I was like, okay, so we had positive nuchal rigidity. She absolutely refused to move the neck muscles because she knew that it would be immediate severe pain. And she was kind of doing this motion for all movement of her head up and down. So from there, I went and talked to our physician on the staff, and I was like, this is what I think I got. This is what I want to do. And I kind of told him, I was like, to me, it seems so clinically positive to call it aseptic meningitis from the drug. She's very stable, to just simply stop the drug instead of sticking needles in and sending her CT and all that stuff. And he was like, I agree with you. So we just simply stopped the drug instead of doing a big full workup. And when I tell you I had close follow-up with this person, like I called them every 2 hours. Like, you still good? You still okay? Please tell me you're still alive. And just within hours of stopping the medication, she said that the photophobia started to go away, the headache started to go away, and within about 12 hours, almost back to normal, and within 24 hours, all symptoms had completely resolved. And then at that point, she was like, is this why when I drink wine high in sulfa, I get the same headache? And I was like, yeah, don't do that anymore. So, wish you would have told me that earlier. Okay, so there's some kind of conversation on meningitis, why the meninges are irritated, is positive Brzezinski's, and Kermit sign, how that plays into it. All right, atypical presentation in our immunocompromised, that's possible. Just a little bit lower threshold to call it meningitis is reasonable, but there really should be some kind of overlap to the symptoms, even though it might be a little bit softer of a call. All right, clues for diagnosis, this makes sense. I'll let you read through that. The cornerstone of the examination for meningitis is a cerebral spinal fluid analysis. We get that out of there. We can see if there's blood in there, which could be signs of a stroke. If there's not blood in there, they can do all kinds of things for measuring opening pressure, to the amount of protein in it, to the amount of glucose in it, to actually do on a gram stain and or culture with it as well. Just always do a CT before you do the LP. Here's a chart that I recommend taking a little bit of time to look at. I don't know that it's probably value added to memorize this verbatim. If you can, great. But really look for some commonalities and something that'll stick out that would make something more likely than another. So for example, the bottom line here says normal values. And if we were to look at normal pressures, for the most part, these are close-ish to normal, whereas bacterial meningitis would have a significantly higher opening pressure. Bacterial meningitis, a high increase in polymorphic neutrophils, whereas those PMNs are not nearly as present in the other causes. So if you kind of take some time and look at this, anything with the glucose and the protein compared to others, you might find some commonalities that will tease out a likely pathogen versus another. All right, a couple of biggies. Neisseria meningitidis, #1 cause of bacterial meningitis in children and adults. And honestly, it's probably moving towards just being the #1 cause as a whole. Strep pneumo and Haemophilus influenza are the other two that are the most common bacterial meningitis. In neonates, group B, E. coli, and Listeria. Where else did we talk about Listeria? Anybody remember? What type of patient population specifically? Regularly, we don't want them to get Listeria because it can cause a lot of problems. Neonatal meningitis is one of those problems. All right, strep pneumo. I don't like the way that this slide is worded because at the very top, it makes it sound like strep pneumo is the most common cause. It just is a very common cause, and it is a very common cause. But please remember, there are a couple other most commons that we're going to look at. So strep pneumo, if you have a strep pneumo, the treatment is cefotaxime or ceftriaxone plus vanc plus dexamethasone. And you can read through there as well. Some other options that we can treat that way. Neisseria is the most common cause of bacterial meningitis in the U.S. in most age groups. It's a very, very common cause of meningitis. So on top of the normal meningismal signs, Neisseria meningitis comes with this petechia rash on the extremities that can cause a lot of purpura as well as necrosis of tissue. That's kind of one of the things that gets tacked on to Neisseria in the meningitis picture that is kind of a telltale sign of it. So I highly recommend kind of just looking at that, appreciating what's going on. What's happening here in Neisseria meningitidis, it's in the body. As it prolificates, it creates a toxin. That toxin hits the endothelial tissue, creates a lot of porousness, and a disseminated intravascular coagulation picture happens. All of the clotting factors that are in the blood are used up. Now we have this bleeding issue, and that's where this purpura and ecchymosis comes from. Have you guys talked about DIC yet, disseminated intravascular coagulation yet? I see some yes and some no. My guess is you probably talked about it a minute in Clin Lab and a minute in pathology. You'll definitely talk about it again in EMOC. Do you guys, this is not like coming down to like a lower level, just making sure. There's clotting factors all over the blood. Would you agree with that? They're just living in the blood. Once something happens, a clotting cascade happens, and a blood clot happens. That's normal. You can have too many of those clotting factors, which makes people hypercoagulable, or you can have too little of those clotting factors, which makes them hypocoagulable. They bleed easier. In disseminated intravascular coagulation, the body basically has this syndrome that kicks off, and it utilizes all of those clotting factors almost immediately. So now the body does not have rotating or floating coagulation factors in it, so it cannot create new blood clots. So would that lead you to more bleeding or less bleeding? More bleeding. So the name doesn't always make sense. You would think disseminated intravascular coagulation sounds to me almost like a hypercoagulable state because there's clots everywhere, but in reality, those little mini clots that have created all over the body aren't big enough to do a lot of damage, but it's used up all the clotting factors, and now you have a hypocoagulable state, and that's what's created in this Neisseria meningitidis picture. So not only is there a DIC type of picture happening, the endothelial tissue is damaged, and so it leaks blood and fluid out of it, and so on the skin you will get these purpura all over the skin. And then because the blood is now leaking out of the vasculature and not going to the end organs that it needs to, a lot of necrosis can happen as well. There are several serogroups, and I need some help if I can. The third one down, it says the Hodge has mostly A and W serogroup. I cannot figure out what that means. Does anybody know? I'm like being serious right now. This was written by an older PA, an Army PA, and so this, in context, this sounds like a geographic location. Like,
Is there a geographic association with like the Arabian Peninsula?
so that's what my guess is. But when I like Google the Hodge, it talks about a pilgrimage, like a religious pilgrimage, which is more of an event versus like a geographic location. But like in the Air Force, which is what I retired out of, we would call Al-Udeed the deed. Is there any like Army spots that the Hodge is like short for or anything like that you want to? No, okay. So I don't know what it's referring to. I was just going to ask you guys because you guys have so much experience, see if you guys have heard of something like that. Anyway, my guess is it was shorthand for something, or maybe it is related to the actual religious event. I am not sure. Either way, I won't ask you a question on that one. Is that okay? I probably won't ask you a question on this slide, and everybody deletes it. All right, moving over to Listeria. We know that this can hit certain populations. The pregnant population is one that gets the most notoriety for Listeria, but it can hit in others as well. AMP and GENT is how you would treat it. All right, some more treatment considerations. Isolations for 24 to 48 hours. Whether it's viral or bacterial, you want to take that person and isolate them. And to be fair, nobody with meningitis or encephalitis is mad to be isolated. You stick them in a dark room, quiet room, and they're happy to be there. Yes, sir. Did you figure it out?
Yeah, I asked Rock, and apparently it does have to actually do with
Okay, cool. Contextually, the slide made it sound like a little geographic location, and that's why I couldn't hear it. That's okay. Antibiotics for all patients with meningitis, and then of course we would adjust them when we got a culture back if we needed to adjust them. There is some post-exposure prophylaxis that is reasonable, so if you have somebody who was in close contact to somebody with meningitis, treating them as well is not a bad idea. Ceftriaxone is a very common one only because Neisseria responds well to ceftriaxone, and that is a very common cause in that adult population. All right, when it comes to viral meningitis, there's a couple of big ones. Enterovirus, herpes virus, arthropod, HIV, could be parasitic. Amoebic meningitis, that's kind of going to that Naegleria fowleri picture again. That's not the only one, that's just the one that freaks me out. Fungal, and then of course there's some unique ones. Tuberculosis can kind of do anything, go wherever it wants to, and syphilis can also kind of go anywhere and do its own thing as well. What a unique story this is. There was a compounding pharmacy that had a meningitis outbreak. There was a fungi found in contaminated sealed vials of methylprednisone used for epidural steroid injections. And so they utilized medicine that was contaminated and caused a lot of sick people. Look at that, 720 sick, 48 dead from a fungal meningitis. All right, some clues from the H and P that can be helpful. And look at the very top one, purpura, likely organism Neisseria. And that's one of the big things that I took away a long time ago. And sure enough, if I hadn't seen so many meningitis questions and patients that had that purpura on their extremities. You can read through this. As you see, there's a lot of overlap. This is meant to just be a useful guide to help you in your evaluation of the patient. All right, treatment. Viral meningitis. Most are benign and self-limiting. Please don't mistake the word benign for like asymptomatic. These patients can be quite in pain. However, supportive care on a viral meningitis is what you need. Again, let them go sleep it off in a dark room. Lots of hydration, lots of nutrition, some pain medicine, etc. Fungal, TB, and syphilitic, you would treat them according to the actual fungus, the TB regimen, and the syphilis antibiotic. The differential, this should make sense, right? If we have any of these things going on, it could mirror that fever, headache, photophobia, seizures, etc. All right, we're going to talk a minute about prion-related diseases. This isn't overtly an infection because it is kind of an infection. Prion is a misfolded protein, and it can be kind of get into the body for a handful of different ways. If you guys have ever heard of Creutzfeldt-Jakob disease or mad cow disease, these are types of prion-related diseases. What ends up happening is these prions, or these misfolded proteins, get deposited into the central nervous system or the brain tissue. They just live there, and it can take quite a while for them to do enough damage before the individual is symptomatic. A lot of times you'll end up not recognizing this in the patient until they're older and have dementia, and as they progress, you realize, okay, they don't have like Alzheimer's dementia, they have prion-related dementia. It's been eating away at their brain tissue for a while. But it lives in cows, and specifically the brain tissue, and so there is some risk for people who eat bovine brain to get it as well. It can be inherited, sporadic, or infectious. All prion diseases are fatal. And look at that, it usually presents in the 6th or 7th decade of life. It just takes a long time for it to become symptomatic, so people don't know to be looking for it until it's symptomatic. A lot of these are demented patients that were looking for other reasons of their dementia, and they kind of find it at that point. There's not a lot of great tests for it. There are some developing PCRs. We can do some imaging, and we can see some increased protein in the cerebrospinal fluid. There's really not a great treatment for it, and the biggest thing to do is avoid it, and you avoid infected material. Brain tissue, eye tissue, and look, there's even a risk for some cornea transplants if they come from like a living model or whatever the case is to do it. Or if there's any type of medical instrument going into the actual central nervous system and it's cross-contaminated, that can be a process for it as well. I'm not worried about chronic wasting disease per our conversation. You can read that slide if you'd like. Differential, this is for that prion disease. You can read through that. And that is it for encephalitis meningitis. Lots of slides, but really not a ton once you start to distill out those key points. Can we get started with the musculoskeletal system and just see if we can get into the rickettsial stuff as well? All right, infectious disease related to the musculoskeletal system. Without us, kind of like we do with encephalitis and meningitis, we're not looking at very specific pathogens. We're like looking at infectious diseases that hit the different parts of the musculoskeletal system. Without even thinking about it, you guys can probably think of 2 or 3 right off the top of your head. Septic joint is a very common thing to have happen. Septic bursitis is a common thing to have happen. And then osteomyelitis is another very common thing to have happen, all related to the muscles, bones, joints of the musculoskeletal system. When a pathogen gets into a place it's not supposed to be and kind of proliferates and causes a problem. All right, typically these happen with some type of predisposing factor. A lot of times there's a hematogenious spread and usually involves large joints and tends to be monoarticular. All right, when you have somebody with a sudden onset pain, decreased motion, the joint, fever, swelling of the joint, effusions, warmth, and it's monoarticular, you got to think infectious etiology, especially with an elevated temperature. Just A&P styles. All joints you recognize are encapsulated, correct? Where those bones touch each other, move against each other, there's a little capsule that covers it. That capsule keeps it safe, as well as keeps synovial fluid inside to lubricate that joint so it can move around as smoothly as possible. What is an abscess? It's a walled off pocket of bacteria that's producing pus, and it becomes pressurized, like a giant balloon. That's what causes the pain of an abscess. So when you think septic joint, it's functionally turning into an abscessed joint. That bacteria gets in there, it proliferates, it has a lot of byproducts like pus, blood, exudative tissue, and it's now all of that pus under pressure because it's encapsulated into the actual synovial joint, and it creates a ton of pain. The problem with this is not just the pain, but the inflammation degrades all of that cartilaginous tissue. It eats up all of the synovial fluid, and then that bacteria actually will start to inflame and erode the bones itself. It can cause a ton of problems to the joint itself within a very short period of time. So a high index of suspicion, a quick treatment for it is always wise if you think that you have an infected joint. Knees are pretty common. I've seen several infected knees. Lots of times they're after some type of joint prosthesis or joint surgery because of just the trauma involved with that. Staph aureus is a number one cause. Staph is everywhere. It just gets into the joint where it's not supposed to be, and then it happens. If you have a prosthetic joint, methicillin susceptible or resistant Staph aureus or coag-negative staph, and Staph epidermidis is also at play as well. Neisseria gonorrhea is a top cause in those under 30. Why would that be something for somebody under 30?
Sexually active.
So you guys remember when we were talking about sexually transmitted diseases, we were talking about gonorrhea specifically, and we said that it can get into joints, like it can spread through the blood and deposit itself in the joints. Under 30, just statistically speaking, tend to be a little bit more sexually active, so higher risk, more likely exposure. If they get infected with gonorrhea and it gets into a joint, so it can be a little bit more common in the younger age to have Neisseria as the pathogen of an infected joint. This kind of a diagram here of what we're looking at. Top left, you see that normal joint, just beautiful bone tissue, marrow tissue, that nice cool looking liquid that separates the two to offer the movement against each other. And that inflammation, it just kind of like turns both of those bones into 80-grit sandpaper trying to rub on each other. It hurts like crazy. All right, x-rays may or may not be helpful, and a lot of times they won't be helpful, especially early on, because they're only helpful if the infection is so bad it's growing, displacing tissue, or it's actually starting to erode tissue. So it does take a little while to happen, but most people will get an x-ray as part of the initial process as well. Antimicrobial therapy, we're going to aim it against the organisms at play here. So empirically, we can aim it at Staph or Neisseria if we want to, and that's why we would, where we would start. We can also take some of the fluid if we pull it out of the joint, send it off for a culture and a gram stain, and then see if it's susceptible to anything different. Nafcillin or oxacillin, if you have methicillin susceptible. Vanc if it's resistant or coag-negative. Then we have ceftazidime and ceftriaxone for gonorrhea. All right, septic bursitis, not a whole lot different than the septic joint. It's just a different spot. You guys remember what bursa are, right? Those little sacs of fluid that are all over your joints. It allows ligaments and muscles to sit on top of them. It keeps the whole area kind of lubricated so things move back and forth nice and easily. And a lot of septic bursitis kind of can lead to a septic joint if it's not treated appropriately. Now, there are a lot of people who will get a bursitis, which is just an inflamed bursa sac that's not septic in nature. A lot of times use, overuse, or just a friction will cause it. You guys ever heard of tennis elbow? Right? And it's always kind of right here on the lateral epicondyle. It's because that backhand motion of tennis players tends to cause a lot of friction right there where that epicondyle is and over that bursal sac, and it can be very painful. Ever heard of golfer's elbow? It's just the other epicondyle, right? That's because it's the opposite motion. These people have a repetitive motion that constantly puts friction on these certain specific bursal sacs, and it inflames them. So bursitis, by definition, is not infectious, which it can be from a lot of things, but we're talking about the septic version or the infectious version of the bursitis here today. Staph is the most common, and that can be the first sign of a septic arthritis in patients with rheumatoid arthritis. olecranon and patellar joints are very commonly impacted, and the labs and the treatment is the same as the septic arthritis. Everything that we just did for the joints, we would do for the Bursitis as well. All right, it is 10:48. Instead of starting osteomyelitis, let's go ahead and take our break. We'll start with osteomyelitis when we come back after that.
Every video, bro, I'm just like listening to the break. I'm listening to the break for all 6 minutes. Let me double check.
I have no idea. That little like
Because every time we send like
I know had both like options, but under the face points, so that makes sense.
Two minutes after he was born, I was like, shit go. It looks so bad.
So I'm trying to plan everything. Yeah. Let me know just what dates are fine.
Well, what are you looking at?
So like
Look
if
at the calendar.
so
So when do you finally?
so if we have that test on that Wednesday, then I would want to be on the road on Thursday.
But if you have it on Thursday, then you're on Friday.
Yeah.
Okay. And then, yeah, how long does it take you? Like 3-4 days?
Like so like it would probably be a whole like a week just because like I have to work in like the next week. So like my plan was like to then fly back that following, so it's the 24th, so the 23rd, 24th. So then I would fly back on either that Thursday or Friday. That's what I'm looking at now. That's too much. Let me know.
No, so I think I was gonna talk to you, May. I mean, we split them.
Yeah,
So like one of us does the morning, one does the evening.
which is fine, but then also that's runs 10 Western Earth. You said that yesterday, so
But I don't mind doing it. I'd probably do 2 trips. I do one in the morning, take them out for a walk, feed them, and then like go do whatever I do, and then come back later.
that's fine. Yeah. The cat's not really much to worry about because
And litter.
you don't worry about it because like how it's set up, like only thing you have to worry about is water. Because it's the same water, he's an automatic treater, so it's just like it's really just like
Any let them roam inside?
so she is my dog is kenneled because like she'll get anxiety and then like want to chew and shit. So she's kenneled for most of the time.
And how long is the most you let her go without like a piece?
Like 12 hours. Because it's like cause like my when she was like when I was in her apartment in Gainesville, she would have to go to like work from like 8 to 8. So like that's like so she was in the whole time. I might set it up in my bedroom where like I make sure there's nothing that she can get onto, so like she tries like to leave her out in the bedroom. It's like she'll do shit like chew on the windowsill.
Yeah, I think it's anxiety.
Yeah, it's
It's usually a puppy thing when they're young.
I mean, she's not a puppy.
Yeah, but when
She's anxiety. But
yeah, that's what's fine.
yeah, whatever you want to charge, I'll pay whatever.
You just turn that off. You don't need it.
Where do you live?
It's on the website. It's like right across from Blackland. So from your house, like you can get on 410.
Yeah, I know.
You can get on 410 and get out with that bar and get right off of there.
I'm on it too. I thought I bought one, but
I go like after the gym.
Yeah, that's fine.
I'm looking at this class when we PCS. Like a Zoom class, so I would probably be on Zoom the whole ride. I have nothing else to do.
What classes?
So it's like Zoom.
Yeah. Which
I mean, those two are what's otherwise I'm listening to podcasts. I like listening as much as something like that. I'm listening to it.
I don't care.
Look, well, if you mirror, we finish the second one.
Yeah.
So then I match. We start and I saw the staff of conference, which is usually that last week.
It was last year.
I'm sorry. Why? You would have told them to put more in.
It's just like water.
Very
No.
neat.
I know. I thought you don't drink coffee. I
She's
don't.
a new
but I'm
girl.
What?
New year, new her. She's growing up.
Oh, maybe it's coffee. Exactly. Tell us your secret.
Never drank it, so I never eat it.
I never did either. Look at me.
When did you start?
This semester.
It's like 6, 7.
6, 7.
What time do you sleep?
10.
10. What time do you wake up?
It's a good amount of space.
Actually, this semester, usually I used to go bed around 9:30, wake up around 5:30, but this semester is it's not.
I'm likely to be in bed by 11:30ish.
What?
11:30,
What time do you wake up?
5ish.
I'm getting red.
Same.
It's like,
My best day is like 4 hours.
wow.
I did that earlier.
But you study till like 11.
Your brain's already so tired by now. I can't even reach
In the freshman year, like by 9, my head was like, but I guess as we get done,
you feel the
yeah, it goes.
I guess because I used to cut off studying at 9, now I can go up to 10.
But before it was like my head hurts, like I don't know.
I don't know.
I would think that's a break. That's that. You can like
But I am like,
start studying even longer. It's also
I know. I keep like looking at it.
9 max now.
9:30. I call.
You should by 10. I'll be on it. Why did I am falling asleep at that time?
I put off at 10.
I still hear cadence. I still hear cadence.
Oh, you hear.
I still hear cadence.
I 10 at 9.
You live on Bruce? Oh, that's terrible.
Yeah, but 10 at 9.
And they're not
Where the
supposed
hell
to
are they
play.
going? They're smoking them.
Is it smoke? Oh, that's terrible.
They're like, ooh, shit in the shower.
Almost popping. Oh.
You're fine.
I TV.
See, I'm not.
Sometimes I'm on my phone once I lay down, scrolling through Insta, Facebook.
She doesn't like some people. Yeah.
He's like, if I gotta talk to you, I'm gonna talk to you. Just like that. After a guy does something great, it's always nice to get something funny.
That's really posted.
And everything's fucked, it's long. The seniors put it up.
Where?
Jimmy Twins bathrooms downstairs, like Quinn Skills Lab. It's like in between the two bathrooms, there's the wall where they show like the graduation, the IPAP graduation. What's it called?
Alright, you guys ready to go? Osteomyelitis. Break down the word osteobones. Mya is the muscle, and itis, so it's inflammation of them together. And a lot of times that bone is what is the biggest concern of an osteomyelitis. But that infection that's in the bone typically goes through skin and musculature to get there. Not always, but a lot of times it does. So you end up kind of like with this like large inflammation of the surrounding tissue of the bone as well. There's two types of osteomyelitis, acute and chronic. Acute is exactly what it says, usually within a couple weeks of something penetrating the bone. Then that bacteria proliferates, creates an abscess. That abscess decreases blood flow. Now you have necrotic bone tissue as well. Chronic osteomyelitis is this kind of consistent worsening of osteomyelitis that never really got all the way better. It gets bad, has necrotic tissue, it kind of gets a little bit better, then it gets bad again, chronic tissue, or necrotic tissue, and just continues to get worse and worse and worse. And if you have somebody who has a history of acute osteomyelitis, that's a huge clue that they are maybe currently experiencing a chronic osteomyelitis. All right, let's talk about it here in general. Trauma to the periosteum is one way that you can get this. Just the bone itself gets traumatized, right? An open fracture or a deep wound or a post-surgical type of thing can cause the actual bacteria to get into the bone itself. It could have contiguous spread. Secondary to surrounding tissue that's infected, kind of gets down to the bony tissue as well, or hematogenous spread through the bloodstream down to the bone itself. All those are ways that it can get there, but ultimately the bone itself has gotten exposed to some type of bacteria. Now the bone and the tissue around it have become inflamed. There's a lot of correlation to ulcer development on skin next to bony tissue that can then create an osteomyelitis picture. And osteomyelitis, one of the cures for it isn't just antibiotics, but if there is necrotic bone tissue, that tissue's got to be removed, or it's just going to worsen with time and create a chronic picture. So individuals who have some type of pressure ulcer or bed ulcer, if they're not treated kind of aggressively and appropriately, they can definitely create a osteomyelitis picture that can then lead to an amputation as well. And a lot of those are diabetics as well. Very, very problematic for the diabetic population, what we just described. When it comes to ulcers, you can have staging of ulcers. Have you guys talked about this in ortho at all? staging of the pressure ulcers. We'll mention it here. It's kind of good to know. You'll talk about it in derm as well. If you guys have never seen a pressure ulcer, just think somebody laying in bed for so long that there's a friction point, a bone plus the skin rubbing on a mattress sheet, a bed rail, something, and eventually a ulcer presents. That now is a break in the skin, which is supposed to protect the bones and the muscle from all the outside pathogens, and now it is not there to do its job. You can read through this. Stage 1, just intact skin. Stage 2, we're looking at a partial thickness loss. Stage 3, we're full thickness loss. And stage 4, all the way down to exposed bone. So like that ulcer's just gotten eaten away slowly by necrotic tissue and friction. It's not just the scenario I described where it's like bed sores or somebody laying in bed. It can even happen from somebody who's not aware of like a nasal cannula and they get a pressure ulcer behind the ear. They may not even be aware that it's there until all of a sudden they kind of like touch it and it's hot and tender and stuff like that. So it's very possible that they have it. There is one stage called, well, it's not a stage, we call it unstageable. Basically, it's a full thickness ulcer that is so obscured by skin sloughing into the ulcer itself, they can't actually explore and stage it. It needs to be debrided surgically for it to actually understand how bad it is. And then there's this, an item called a suspected deep tissue injury, where it's a purplish area due to damage of underlying tissue, and the evolution may include a thin blister over a dark wound bed. And so they're actually, in that situation, the injury is much deeper, but the skin has not ulcerated yet for you to visualize it. Here's some kind of diagrams to kind of talk about. When you're evaluating rashes or skin changes, a lot of times the first thing people ask, is it blanchable or not blanchable? So blanching means you push on it, that redness goes away for a second, and then when you remove your finger, that pallor that you created by pushing on it goes back to being red. A lot of rashes will have a blanching nature to them. If you have a bed sore or ulcer or ulcer being developed, it is non-blanchable. It's because that damage is pretty significant to that tissue. You can't actually move the blood out of it when you're blanching it. So stage 1 is an example here as well as a repeat of the description. Non-blanchable erythema, but the skin is intact. Stage 2, partial thickness loss, exposed dermis. Stage 3, pretty full thickness loss, visible adipose tissue. So the ulcer's gone all the way through the dermis, and you can actually see that yellowish globular adipose tissue being eaten into. And stage 4, you're now actually starting to see bone exposed because that ulcer has eaten so much of that soft tissue away. Unstageable, it's just so full of material that it's kind of fallen into the crater of the ulcer that you can't stage it. That thing needs to be cleaned out and debrided to understand how bad it actually is. I mentioned this already, medical device, like if somebody has maybe a breathing tube in, a trach in, nasal cannula, if that's left in place for a long time, especially with somebody who maybe is in a coma or something, those friction spots as well can cause ulcers. All right, the presentation, a lot of pain, or can have a lot of pain, muscle spasms, a draining sinus. They're not talking about like our maxillary sinuses. What they're talking about is a fistula can create from the actual abscess in the bone through the skin, and you can just see an opening with like purulent, mucopurulent drainage coming out of it. Fevers, chills, erythema, always also positive are possible. You can follow your ESR and CRP. In other words, you can kind of like take them regularly to see if they're getting better. Blood culture is great. Bone and needle aspirates are fine. Don't culture from the superficial sites. You'd actually want to culture from the bone itself. If you are going to order a culture or somebody on your team is going to do a culture, you would want to stop the antibiotics. So either do it before antibiotics start or stop the antibiotics for a little while. That way you have a better capability to get a true culture grow out and evaluate what it is. Here's just a couple x-rays comparing healthy bone to osteomyelitic bone. Look at the tibia on this. And like, I think way up here it's easy to appreciate all of the hypodensity that's happening here, but look at this down here. That's just straight missing a piece of the bone that's been eaten through. have you guys heard the phrase malunion and non-union yet? Right? So malunion means it's joined together, but it's like not joined really well. Non-union is still kind of like floating against each other. A lot of times in these chronic osteomyelitic pictures, you'll get either a non-union or a malunion of bones, where they are trying to get together or they just simply can't, and they're kind of floating on each other. I remember I was early in my PA career, and this individual walked in, and he was like, for ankle pain of all things, and I was like, all right, let's see what we got going on. This dude was one of the biggest dudes I've ever seen, and like the legs were huge, and they were completely purple because of like terrible vasculature. And I was like, what the crap is going on? And I kid you not, like think tibia fibia, right? Like, and there's no tapering to it. It's just straight. It's a trunk, right? Straight down. The bones were offset like this so bad that you could watch them working against each other. He was walking on it. I was like, bro, what are you doing? He goes, I just think I twisted my ankle. I was like, no. What is wrong with you? So he's diabetic. He had an injury, a very bad surgery. He had a malunion that had now turned into a chronic osteomyelitis that created a non-union. The bones actually had separated each other. And every time he walked, they just kind of pushed against each other. But his nerves had become so deadened to the fibrotic tissue around it that it didn't really hurt to walk on. He was just walking on it. And I mentioned a minute ago, what do you got to do with necrotic bone tissue? Cut it out. And so I was like, and we had an orthopedic surgeon in the clinic I was working at, and I was like, how long has this been going on? He's like, about 2 years. Oh, that sounds terrible. And he was like, I'd like to go see a new orthopedic surgeon. My other one isn't doing a very good job. I was like, yeah, I agree. Send him there, and the surgeon, he was like, I'll cut it off for you. Like, that's the only thing I'm offering. Like, there's no fixing this. There's no fixation, nothing. The guy came back to me, and he's like, I don't really want to cut it off, though. And I'm like, I don't know what to tell you, man. Like, there's not an antibiotic I can give you that'll fix it. There's not a splint, a cast, a surgical intervention that'll fix this. Like, I get you don't want to lose your limbs, and losing limbs is a big deal, especially with a diabetic, scales diabetic. When you lose that first limb, you have that first diabetic amputation, it doesn't stop. It just slowly works its way up to the body because now whatever got cut off, that new stub is the smallest vasculature in the entire body. And that's what the diabetes is going to eat away, more necrotic tissue, and you just slowly remove parts of the body. You ever hear somebody, like old school way of saying this, the person got eaten alive by diabetes or eaten alive by cancer? That's what they're describing. They just slowly had to cut off part of the people because of necrotic tissue. So in this case, he was very resistant to have it removed, and I was like, I feel you. There's just really not a lot of options, and so he had to go into the decision-making process there. But what I couldn't believe was the chronicity of it and how it didn't appear painful to him. He was just straight walking on it. So it was right by his ankle, where this it was wild. Okay, we can move on. Just some more X-rays of osteomyelitis. Show you how it kind of like gets into the bone, can create that abscess, be a terrible eating away at the bony tissue. It's a big ulcer, right? You guys talked about diabetes and endo yet?
So just
Not next semester. So have you guys heard of, in diabetes, you always tell people good foot care, right? Like take care of your toenails, wear shoes in the house. The reason is with diabetes, they'll get terrible complications to the vasculature that is the smallest. Well, whatever is farthest away from the heart is the smallest. So the toes and the feet are the smallest. So they don't feel really well, and they don't have good blood supply. So if they injure their feet, they don't know that they've injured their feet a lot of times. A lot of them are so obese they can't look at their own feet. So we tell them wear shoes in the house so you're not accidentally stubbing your toes on the counter or stepping on a tack or a splinter or something like that. Because they'll end up coming in and they'll have a big old ulcer on the bottom of their foot. Maybe not this bad, that's pretty bad. They won't even know that it was there because they can't feel it. They can't see it. They can't clean it. And by that time, the blood supply is so bad that it can't fix itself as well. And then they go into this state, this rhythm of they get an ulcer, it won't heal, it gets amputated, they can't take care of it, they injure it again, it won't heal, they amputate it, they amputate more, and stuff like that. So it's a pretty big deal, especially for a diabetic or somebody with peripheral arterial disease, peripheral vascular disease, to take really good care of their extremities so that these ulcers don't happen, because a lot of times they won't even recognize that it happened. Oh, and toenails are the worst. I would send my diabetics to an actual podiatrist for toenail care. They can't take care of their own toenails, they'll get wildly ingrown, and as soon as you try to address them, you've now created a wound because you're pulling it out of a wound that's created and kind of plugged itself. Vile, disgusting thing. God bless podiatrists. Could not do it. Alright, osteomyelitis, continuing on. Etiology, Staph aureus is most common, coag neg, staph, enterococci, gram neg rut, all of it's there. Look at the bottom bullet. I'd recommend circling that one for whatever reason. I don't know if you guys know, by all means tell me. Sickle cell individuals have this predilection to salmonella being a very big problem for them. So salmonella causes a lot of problems in terms of osteomyelitis for those with sickle cell disease. Other pathogens could be involved as well. X-rays, they are not necessarily diagnostic, but we can get an idea of how badly they're impacting the bone itself. Bone scans tend to be some of the most helpful. That's kind of the third one down. MRI and CT can be helpful as well. This just kind of gives you a reminder of the anatomy and shows that metaphysis is a very common place to get. The treatment of it, you're going to treat whatever you feel the causative agent is, right? So if you think it is a bacteria, which it probably is, it's very likely to be, start with something broad that covers staph, nafcillin, oxacillin. If you think you have a resistant staph, Vanc is a pretty good one as well. And just like I described with these individuals who have very difficult vasculature, increased oxygenation and perfusion to the tissue that's dying is good. Hyperbaric oxygen is a great option. A lot of people with osteomyelitis, chronic ulcers, diabetic skin disease will go into hyperbaric treatments as well. An excision of necrotic bone is essential. If it's dead tissue, it's got to come out of the body. If it doesn't come out of the body, it will just absolutely continue to grow after you sew it up. And there's a model they have when it comes to the remission of osteo. Once it's osteo, it's always osteo. It's very hard to truly get it out of the body once it develops in that chronic state and it doesn't get treated appropriately the first time. We talked about this a little bit, pathogen specific. We can do some empiric therapy. If you have MRSA, we'll use Vanc. We mentioned that already. This second bullet, a nail through the tennis shoe, which is kind of a classic presentation. If you're worried about it, they used to suggest Cipro for it. However, according to Stanford, there might be a different indication. Ultimately, recommend going with whatever your local antibiogram suggests. Have you guys heard of Stanford's Guide to Antibiotics? Have you heard about that yet? It might have gone away. It's not as popular anymore. When I was in y'all's shoes, the pharmacist was talking about Stanford's Guide to Antibiotics. And it was this pocket guide that was super thick in written 0.5 font. And just had these greater than, less than signs, percentages. And I was like, I can't read any of this. I have no idea what it is. But they swore by it, probably because that's what they taught them. If you guys are ever interested in a antibiotic guide that is wildly user-friendly, the EMRA antibiotic guide is the greatest antibiotic guide ever written known to man. The Emergency Medicine Residents Association, EMRA antibiotic guide, this is why it's so good. They color code it to the system of the body. So if you have a pulmonary infection, you just go to the color of the pages, that's the pulmonary infection. It says most common of organisms, use this one. If it has this allergy, use this one. It is bulleted, it's simple, easy to read information. Absolutely love it. The thing that I love about that antibiotic guide, even more so than all the others, is that it will give you a common time to keep them on antibiotics for. A lot of guides, especially even up to date and stuff like that, they won't say use this antibiotic for this number of days because different infections have a lot of different timing to be on antibiotics. But this antibiotic guide does a really good job of also offering information about how long to be on it for. So I don't own any stock in the product. I still have mine from 2012 or something like that, and it's still pretty accurate. Very, very easy to use. Yes, sir.
Are there any MTFs that have hyperbaric chambers?
Yes. Not smaller ones, but there are out there. In fact, I would expect that the majority of the places you guys will go to phase 2, because you got to go to phase 2 where it has access to all of the rotations, right? They likely will have either hyperbaric or access to hyperbaric on the economy because they're going to treat sicker patients. Where I was at in I did phase 2 in Chavez Air Force Base, Bay Area, California. They had an entire hyperbaric clinic, and we could do elective rotations in there if we wanted to. All right, prosthetic joints absolutely can get infected as well, usually due to contamination at the surgery. Usually, if they're going to be infected, it's within 6 months of the operation, but not necessarily. Similar signs and symptoms to an infected joint. Same labs as an osteo. Radiology findings, you could have some periostititis, which is just scalloping of the bones. And there's twofold treatment. One, you got to get rid of the actual bacteria causing the problem, and two, you got to maintain the usefulness of the joint itself. And so a lot of surgeons will take a lot of care if they got a high-risk patient when we do a joint replacement to make sure that that joint is cared for well. And if there's problems, they'll address it pretty quickly. All right, that's osteomyelitis. I'm sorry, musculoskeletal conditions. How are you guys doing? It's 11:18. If we open rickettsial diseases, we're good? Let's go. So when I was a student, I was real dumb. I'm not super less dumb now, but I saw rickettsial diseases and I was like, oh yeah, vitamin D, rickets. That is not associated. Do not choose vitamin D a week from Monday, okay? It's not the answer. Rickettsial diseases is diseases related to the pathogen rickettsia or rickettsia organisms. The first bullet you see here says occupies a position between bacteria and viruses. The morphological picture of it doesn't overtly fit one class. That's when this was written. In my updating kind of research of it, most people are consider rickettsia organisms bacteria in nature at this point, and we treat with antibiotics. They're intracellular gram-negative cocobacilli. They don't stain well with gram stains. They can stain a little bit red with Gemsha stains. And mammals and arthropods are the natural hosts, usually transmitted to humans by the arthropods with the exception of Q fever. All right, so this slide deck, we're going to talk about some diseases. Those diseases have their own specific rickettsia organism as a pathology, and so that's what we'll look at. This is similar to Neisseria meningitis in end state, but not in pathophysiology. Look at this first bullet here. It says multiplies within the endothelial cells, the small blood vessels. So if you've got a pathogen that's living in the actual endothelial cell, what does endothelial cells make up? What part of the body? Vasculature, right? Arteries and veins. If they are in the actual cells that make up the arteries, what do you think is going to happen to all that blood that's supposed to be inside the arteries? It's going to leak out due to secondary damage to the actual endothelial cells. Sounds like purpura. Do you guys remember that we talked about petechiae and purpura with Neisseria meningitis? Very similar presentation. The only difference is the pathophysiology. Neisseria meningitis is toxin related. It kind of causes this permeability of the vasculature. Rickettsia is actually proliferating in the actual endothelial cells. Not super critical that we know the difference there, but there is a difference in how it gets to the stage where basically you got a lot of blood that should be inside of an artery or vein, and it's leaking outside of that artery or vein. If blood is leaking outside of that artery or vein, is the tissue that is supposed to perfuse getting perfused? What happens to tissue that doesn't get perfused? Dies. So just kind of talking about this intellectually, should we see a rash of petechiae, purpura, easy bruising? Good chance of it. Is there got a good chance of necrotic tissue? Good chance of it. And so it's pretty complicated disease processes here. Treatment is Doxy. I love Doxy. I also like Doxy's the dog too. But doxycycline tends to work well with all rickettsial diseases. And again, the endothelial lining is what's impacted here. All right, louse-borne typhus. Louse is a lice. It carries Rickettsia prowazekii and causes louse-borne typhus, not typhoid fever. There are a lot of similar sounding parts of words. Please just take the effort to make sure you know what you're reading and looking about. So louse-borne typhus, transmitted by lice. There are epidemics around the world. A lot of times associated with overcrowding, because that louse or lice will jump from person to person. And it's carrying Rickettsia prowazekii, causing this louse-borne typhus. Abrupt onset, 1 or 2 weeks following the exposure, a fever and an intractable headache. What does the word intractable mean? What's that? Non-fixable. It is so bad, there's nothing that'll touch it. It is a terrible, bad headache that we can't work on. Then a rash. The rash shows up in days 4 to 7. That rash is secondary to, again, the endothelial damage. But take a look at the rash itself. Starts trunk and goes to the extremities. So it starts on the torso and it moves towards the extremities. That's different. RMSF, we'll read about it here in a minute, is Rocky Mountain Spotted Fever. Rocky Mountain Spotted Fever goes the other way. So just take the time to appreciate which direction the rash is going in louse-borne typhus. This louse-borne typhus rash also spares the face, the palms, and the soles. It tends to start on the torso, moves out towards the appendages, but tends to not go all the way to the hands. Here's a picture of that rash. Here's some purpura secondary to that endothelial damage, just blood leaking out of the capillary being caught within the skin tissue. Complications, gangrene, pericarditis, myocarditis, pleural effusions, pneumonia. You can even get meningoencephalitis, delirious, and cardiac renal failure as well. All secondary to the endothelial damage, just cannot keep the fluid where it's supposed to be kept at. All right, Brill-Zinsser disease, the same prowazekii. However, this is a relapsing situation of louse-borne typhus. So louse-borne typhus presents, maybe they get better, now it relapses years later, and it's a milder, less debilitating situation. Still has a fever, can have a transient rash, could have low blood pressure. The organisms in the spinal marrow, lymphoid, and adipose tissue after the primary infection. You can see there it can even be 10 to 20 years later. Okay. So Brill-Zinsser is just the relapsed version of louse-borne typhus. And I say that because something else is about to come into play. Murine typhus is Rickettsia typhi. This is a flea-borne version of the Rickettsia disease. From rat to rat, and then by rat fleas. And so if people are exposed to the feces and or the bite of a flea, they can get murine typhus. This is similar to louse-borne typhus in terms of presentation. However, it's much more mild and much more shorter than louse-borne typhus. Well, we already talked about Brill-Zinsser disease, which is relapsing. Louse-borne typhus, which is a milder version. And so murine typhus and Brill-Zinsser disease tend to mirror each other a lot in terms of symptomology, severity, and timing, because it's just a much shorter, relatively easier version of louse-borne typhus. All right, RMSF. I'm sorry that it's not spelled out there. That stands for Rocky Mountain Spotted Fever. And guess where the Rocky Mountain Spotted Fever is not located at? Not located at the Rocky Mountains. All right, tick-borne vector Rickettsia rickettsii, wood tick and dog tick. It's reported in all geographic areas of the U.S., originally thought to be isolated to the Rockies. However, it is not isolated to the Rockies now that we know about it. You can read through that if you want to. Just come on. Look what's not super impacted, not very purple. Right where the Rocky Mountains should be.
Oh yeah, Mississippi.
All right. Lots of signs and symptoms to be concerned for or evaluate for. Gastrointestinal symptoms, skin necrosis, again, we got endothelial damage, cardiac involvement, atelectasis, retinal disease, and enlargement of the liver and spleen. It's a big deal, Rocky Mountain Spotted Fever. All right, here's kind of the stages of it. Abrupt onset, fevers and headaches. Look where the rash starts at. Starts on the wrists and ankles. The one that we talked about louse-borne typhus, where that one start? On the torso, right? And so these are still rickettsial diseases. So it's going to be similar damage, similar symptoms, but the rash starts in different places. And Rocky Mountain spreads centrally, so it spreads towards the middle. And then you can see day 7 to 9, that's really not that long to have a disease to go from healthy to really, really sick. These rashes can coalesce. Really what that means is blood just continues to leak out of the capillaries like it at the vasculature. Gangrene can set in. You could have shock, all kinds of edema, altered mental status, coma, seizures. It's quite bad. There's some pictures of the petechia looking towards the center of the body. There's where some spots where that tissues become necrotic secondary to the hypoperfusion. All right, some non-specific labs, thrombocytopenia should make sense. We don't have the thrombocytes, hyponatremia, elevated transaminases. You could even have an elevated lactic acid, creatine kinase, or white blood cells. Look at the bottom, Doxy is the treatment. Doxy is a great treatment for rickettsial diseases. All right, Q fever. It's its own disease. This one's caused by Coxiella burnetii. And if you're anything like me, you're like, that doesn't say rickettsia at all, and we're in the rickettsial diseases section. It was previously classified as a rickettsial disease, but it's now a proteobacteria. So it's got its own naming classification system, but I'll teach it here because it was formerly known as a rickettsial disease. It's a good spot to teach it. This one directly causes disease in the organs. So macrophages can be in the lungs, vegetation's on the heart, granulomas is on the reticuloendothelial organs like the liver and such. Common in slaughterhouses, research facilities, livestock facilities, in the military. It's employed areas where they have animals that they're in contact with. It can be inhaled or ingested. Usually abrupt onset, fever, intractable headache, chills, myalgia, cough, chest pain, all that. And look here, we call this a rickettsial disease, or at least used to, but there's no rash. Because again, this one is not in the endothelium, it's attacking organs itself. All right, so just a little bit more here about some labs, some non-specific stuff. You might see leukopenia, thrombocytopenia, hyponatremia. Serology for it is kind of the mainstay to confirm the diagnosis. Some other tests that are possible is down here on the bottom. PCRs, a Q fever panel, even a culture is possible. Mortality rates, Rocky Mountain spotted fever without therapy, 25% mortality rate. It's pretty bad. With therapy, it decreases a lot. Improves a lot. Bowel-spore typhus, similar. Brill, Zinsser, and murine typhus, those are together because remember they are very similar in presentation and severity. And then Q fever, pretty low mortality rate. And that's the end of 3 lectures for today. And be here all week. Okay, that's it.